For range of motion exercises, the patient should wear loose clothing, with draping added to preserve the patient's modesty. Place your hands so they provide good support for the patient's joints and allow smooth movement through the available range of motion. Perform several repetitions of flexion-extension. Transition to abduction-adduction. Then internal and external rotation, and conclude with horizontal abduction-adduction. As you progress from passive to active assistive range of motion, maintain the same hand placement so you can provide support and guidance for any segment of the range the muscles are not strong enough to control. With shoulder flexion extension, the patient will need assistance when initiating the range and when completing the range where gravity has the greatest resistive effect. When performing elbow and forearm range of motion, start by flexing and extending the elbow with the forearm supinated. And then with the forearm pronated. Isolate forearm pronation and supination with the elbow positioned in flexion and in extension. When the elbow is in extension, stabilize the humerus to prevent the shoulder from rotating. When performing range of motion for the wrist, make sure the fingers are free to move so the extrinsic muscles do not restrict motion at the wrist. Cupping and flattening the arch of the hand is important to maintain mobility for gripping and releasing activities. You may perform range of motion on the digits one joint at a time or in combination. Achieving range of motion of the multi-joint extrinsic muscles requires moving the fingers and wrist simultaneously, first into flexion, then into extension. Ranges for hip and knee into flexion-extension are combined. Support the knee so it does not drop into extension as the leg is lowered. Abduction is performed with the hip neutral to rotation. Hip rotation may be performed with the hip extended or with the hip at 90 degrees. When rotating the hip in the 90-90 position, support the knee with one hand. For ankle and foot range of motion, first cup the heel with one hand and move the foot into dorsiflexion by pulling distally with your fingers and hand while moving the rest of the foot cranially with your forearm along the bottom of the foot. Then perform inversion and eversion by turning the calcaneus inward and outward. Supination and pronation are complex motions involving all of the joints of the foot. Therefore, grasp around the metatarsals and turn the forefoot inward while raising the arch and outward while lowering the arch. Make sure you include range of motion to the joints of the toes. Full range of motion of the cervical region requires that you position the patient with his or her head off the table. Grasp the occipital region securely, then flex the spine. Nod the head on the neck and then continue flexing the spine by moving the chin toward the sternum. For lateral flexion, keep the spine neutral to flexion-extension while moving the ear toward the shoulder. Rotate the spine by turning the head from side to side. In order to flex the pelvis on the lumbar spine, flex the hips and knees of both lower extremities and bring the knees toward the patient's chest. If the patient is very flexible, you may have to reach under the pelvis and lift the pelvis upward. Good body mechanics is essential. For rotation of the spine, begin with the patient in the hook-lying position. After stabilizing the thorax with a hand on the opposite shoulder, push the knees laterally in one direction until the pelvis on the opposite side comes up off the table. To increase flexion, stretch the shoulder extensors while stabilizing either the axillary border of the scapula or the superior aspect of the pelvis. Apply the stretch force to the distal humerus. To increase abduction, stabilize the axillary border of the scapula. To increase shoulder external rotation, begin with the shoulder positioned in slight abduction or scaption. Flex the elbow to 90 degrees so the stretch force can be applied to the forearm. Stabilize the scapula at the anterior shoulder. To increase internal rotation, use the alternate hand placement demonstrated here. To stretch shoulder flexors, you must place the patient in a position in which the shoulder may be extended past the zero position, either prone or with the shoulder over the edge of the treatment table. Stabilize the scapula with one hand and hyperextend the humerus to the end of its range. When stretching the wrist, make sure you allow the fingers to move freely to ensure minimal restriction from the multi-joint extrinsic musculature that also crosses the wrist. Stabilize the distal forearm and apply the stretch force across the metacarpal region for extension, flexion, radial, and ulnar deviation. Individual wrist tendons can be isolated by aligning the stretch force with a particular tendon. The complex relationship among the joint structures, intrinsic muscles, and extrinsic musculotendinous units requires careful examination to determine what structures are restricting motion. Isolate each joint while applying the stretch force. Stretch extrinsic musculotendinous units across one joint at a time, starting with the most distal joint. When stretching the carpometacarpal joint of the thumb, apply the stretch force to the first metacarpal, not the phalanx.